Hi everyone, my name is Emma Palmieri, and today I will be talking about evaluating test performance in epidemiology. In epidemiology, we rely on screening and diagnostic tests to correctly classify individuals as either having a disease or not having it. But no test is perfect. Understanding how well a test performs is essential when making decisions about treatment, public health action, and of course, disease prevention. Two of the most important measures of test performance are sensitivity and specificity. These concepts help us understand how often a test gives a correct result and where errors may occur. Sensitivity measures the ability of a test to correctly identify individuals who truly have the disease. In other words, it tells us how good the test is at catching actual cases. A highly sensitive test has very few false negatives. The formula for sensitivity is true positives over true positives plus false negatives. A test with high sensitivity is especially useful when the goal is to avoid missing any cases. For example, diseases where early detection is critical or where failing to identify someone could lead to significant harm or spread. Specificity is the ability of a test to correctly identify individuals who do not have the disease. It tells us how well the test avoids false positives. The formula for specificity is true negatives over true negatives plus false positives. A highly specific test is important when false positives have serious consequences, such as an unnecessary treatment, stigma, anxiety, or expensive follow-up procedures. Ideally, a strong screening strategy uses tests with both high sensitivity and high specificity, but in practice, there is often a trade-off between the two. To summarize, sensitivity focuses on correctly detecting disease, while specificity focuses on correctly ruling it out. Both rely on the same 2x2 table structure. A true positive test says disease, and the disease is present. A false negative test says no disease, but the disease is present. A true negative test says no disease, and the disease is absent. A false positive test says disease, but disease is absent. These four numbers allow us to calculate the accuracy of any test using straightforward formulas. For example, let's look at a sample problem. Imagine we have a screening test for disease X used on 200 people. 50 people actually have the disease. The correct test identifies 45 of them. Those are true positives. And it misses 5. Those are false negatives. 150 people do not have the disease. The test correctly identifies 135 as disease-free. Those are true negatives. It incorrectly labels 15 as positive. Those are false positives. To calculate sensitivity, we will do 45 over 50, which gives us 90% of diseased individuals. And to calculate specificity, we would do 135 over 150, which also gives us a 90% of non-diseased individuals. This shows a well-balanced test with both strong sensitivity and specificity. Understanding sensitivity and specificity allows epidemiologists to determine whether a test is suitable for screening, diagnosis, or surveillance. High sensitivity prevents missed cases and outbreaks or high-risk diseases. High specificity prevents unnecessary worry in treatment. These measures guide decisions about which tests to use, how to interpret the results, and how confident we can be in identifying disease in a population. Together, they form the foundation for evaluating any test's validity.